Hello, so this is Chapter 34, Relapse and Other Programs Frequently Encountered in Substance Rehabilitation. Common problems. Limit testing by clients, conscious or unconscious. The counselor and treatment secrets, attempts to make therapists complicit in substance use disorders, a double standard, unreasonable expectations of those with an substance use disorder. Treatment noncompliance, a problem across disciplines. Different factors contribute to noncompliance. Lapse and relapse, 1 of 4. About 99% of treatment programs aspire to the goal of total abstinence. Such a goal may be unrealistic, given the number of people who are not able to achieve this. The term relapse is drawn from the medical model of addictions, reflects a state where the patient falls back into an active disease state after a period of remission. Relapse prevention is an important part of many treatment models. Focus on planning for situations where relapses may be more likely. Factors that contribute to or prevent relapse: self-efficacy, outcome expectancies, craving, motivation, coping style, emotional states, interpersonal support. Though the process of associative learning, a large number of external cues are associated with substance use. Maladaptive thinking that contributes to relapse. Desire for indulgence, may view substances as a reward, may view it as a way to escape reality. Clients may take a short-term view of recovery. Social pressures, spiritual issues can play a part in recovery or relapse. Substitute addictions. Relapse and prevention, 4-4. In a process, not a single event, preceded by a series of subtle, often irrelevant mini decisions that can alert to an impending danger. Prevention, continued group therapy or support, continued individual counseling. Pain, acute pain, chronic persisting pain. Acute injury. Patients with substance use disorders are often at higher risk for acute injury than non-abusers. All too often, pain is inadequately treated, even in patients with no history of a substance use disorder. All patient reports of pain should be accepted, assessed, and appropriate attempts made to address the pain. Substance use history will impact the effectiveness of standard doses of common pain medications. Chronic pain. Chronic pain lasts longer than 3 to 6 months. It is estimated that 10 to 20% of the general population in the United States live with a persistent chronic pain disorder that is not cancer-related. Patients with an SUD should not be forced to endure unnecessary pain because of their SUD. Controlled drinking. Concept met with skepticism in the United States, but not in all countries. Early recovery and sexual activity. People with an SUD may have come to associate certain compounds with sexual activity. They may feel that normal sex involves the use of chemicals. Intimacy without those compounds may feel less satisfying. For all these people, sexual activity, while not intoxicated, induce feelings of inadequacy or anxiety. Interpersonal intimacy might serve as a relapse trigger, yet may be kept secret. So, cravings and urges. Clients should be taught that drug-related thoughts are just thoughts and will come and go, especially early in recovery. Drug cravings is an intense, subjective, emotional, and physical experience for the individual. Cravings are about the brain becoming used to not having the substance when it was used for so long. Cravings are most intense during the first 12 weeks of recovery. The using dream. Frequently encountered though not well researched, some dreams may be relapse trigger. Physiological difference between REM dreams and non-REM dreams. Dreams that take place during REM sleep are noted for being bizarre, intense, and having no logical sense. Another process that seems to take place during the REM dream is that the brain practices the fight or flight response. Anticipatory guidance. Toxicology testing 105. Urine testing is one of the more controversial issues in the field of substance abuse. A positive urine toxicology test is not adequate to diagnose an addiction. It should not be substituted for a clinical interview and medical evaluation. It is non-invasive and painless and allows for on-site testing. There is possibility for false positive results. Other methods may be more accurate, but more expensive and involved. Clients attempt at deception. Substance abusing clients may attempt to manipulate the test to avoid having recent illicit drug use detected. These attempts fall into three categories: in vitro adulteration, in vivo adulteration, and urine substitution. Alcohol, amphetamine compounds, benzodiazepine, cocaine. LSD, marijuana. Some abusers may test positive for extended periods, up to 2 months post-use. Passive inhalation, MDMA, and PCP. Here's sample testing. Scientists have developed the technology to detect drug metabolites of many illicit drugs in the hair of abusers. It is less intrusive than urine testing, but requires 40 to 60 hair strands. Hair samples often offer a detection of 7 to 100 days, but cannot detect ingestion 7 days prior to collection. Saliva. It is still in experimental stages, but may prove to be useful once issues are resolved. Sweat. Skin patches with reactive chemicals can detect evidence of illicit drug use. It may work up to 2 weeks. To avoid detection, some abusers will remove the skin patch the day that it was applied and then reapply it 6 to 7 days later. When they report to their probation officer, employer, and so on to have it removed, some claim environmental contamination, but this is virtually impossible. Funding. Mental health parity laws. Funding dictates form and duration of treatment. Insurance providers are not required to provide funding for mental health or substance abuse treatment. About 77% of all substance abuse-related rehabilitation programs are paid by public funds drawn from state funding. In spite of research showing longer stays improve outcomes, stays of 14 days or less has become the norm. Insurance companies adopt very liberal interpretations of what is considered recovery, as treatment is limited to symptom reduction. So that's it for this chapter. Thank you for listening.